I'm going to talk to you about a new practical approach to the assessment of fetal cardiac function. First of all, do we all think that there's the need for a new cardiac function tool? Yes, I think so, especially in a few diseases during pregnancy, like maternal diabetes, TTTS, sacrococcygeal teratoma, or other structural defects, cardiac anomalies, or IUGR. If I take IUGR as an example, the fetal monitoring comprises of the assessment of Doppler studies, like the umbilical artery, the ductus venosus Doppler, and we use CTG tracings. These are the possibilities we have today to assess fetal condition, but these these parameters only show signs of deterioration late in the stages of deterioration. So we think that the pickup of early signs of decompensation would be very helpful. So over the years, there have been several studies investigating the need of the use of cardiac function tools to assess fetal cardiac function and the fetal condition. Especially the MPI, the Myocardial Performance Index, has been the topic of studies over the last years. This is a technique that gives evaluation of both systolic and diastolic cardiac function. However, this is a technique which is fairly difficult, in my opinion, and it's not easily implemented into daily practice. As most of you will know, the Myocardial Performance Index uses volume shifts. As you use the valve clicks, you can see in the left image is an MPI image of the left ventricle of the heart. You see the mitral in valve and the aortic outflow, and you use the valve clicks as markers to indicate the time intervals between the relaxation and the contraction of the heart, and between the contraction and the relaxation phase. And you divide these, the intercontraction time and the relaxation time, you add these two and divide them by the ejection phase of the heart, and you get an MPI. This is a very difficult image to obtain. It's very easily by fetal movements or other problems, you get loss of your image, and it's very difficult to see these valve clicks in each and every image. So, what I said, it's difficult to measure. It's a huge influence of gain. We tried to get our own reference values in our center, and it's subject to very high inter and intra-observer variability. It has a wide range of the values, and you see that if every center gets its own reference values, because there's no reference range which is usable in every center, you get a lot of different shapes of normal values of this particular parameter. And what I think is very important, you can also only measure the left ventricle using the conventional MPI. And I think that it's also important to assess the right ventricle, since it's predominantly in prenatal life or fetal life. So I think there's the need for a more easy and more reproducible way to assess fetal cardiac function, and it should be possible to obtain images of both the left and the right ventricle of the heart. This becomes possible with the use of wall motion analysis techniques. For example, you can use tissue Doppler and speckle tracking analysis. I will not elaborate further on the speckle tracking, but I will go on with tissue Doppler imaging. With myocardial movement analysis, you do not focus on the tissue movement, which gives a certain blood flow with a certain velocity, but you only focus on the tissue movement, which moves in a certain amplitude. So you do not look at the blood flows, but you only look at the myocardial wall movements as a parameter. Here you see an image of a fetal heart at approximately 20 weeks or so. To the left side, you see a grayscale image of the four-chamber view of the heart. And to the right, you see an image. Oh, where is my button? This is called a color Doppler image of the fetal heart. You see that there's a box really close over the myocardium, and you see the myocardial wall movements like in normal Doppler flow of the ejection phase, we only see now the myocardial wall movements, and that's the flow of the blood flows, of the blood volume. The preferred angle is with the apex to the top to overcome acoustic shadowing. So this is the preferred angle of your image. You should get a real good depth to get the biggest four-chamber view you can get to get the highest frame rates of your image recording. If we now go over these images to see what we can measure in these volumes, if you place a region of interest over the whole myocardium, you get an image like showing on the right. You get a few cardiac cycles with going up the contraction phase and going down the relaxation phase. If we then pick out one cardiac cycle, you get an image as shown on the right. And I will go over these to see what we can do with this. The placement of region of interest is very important. You see that there's a huge difference in shape of the curves. If we go back, this is a region of interest over the whole myocardium. And here on the left and right, you see different ROI placements and the effect on the curve. You will see that better in this video. It takes a long time to load. You see that the shape of the curve will change according to the placement of the region of interest. Now let's go over the MPI. It's a widely used method to get a pulse Doppler and calculate the MPI. It's also tried to calculate the MPI using collar tissue Doppler imaging. If we take a region of interest just above or below the AV valve, you get a shaped curve like this. You can use the zero line crossings like in the normal MPI to measure these intervals. Above you see the contraction, and below you see the relaxation, and you can use the zero crossings as markers of your contraction and your relaxation. And here you see, or you can estimate the AV valve opening like in a normal MPI. But this comes with certain difficulties. I will go over that in more detail. You have certain measurement variables. If we have a good image, we have very clear zero crossings, which are easily seen in this image. But the problem comes with fetal drifting. In fetal drifting, the shape of the curve goes up and down the zero crossing, the zero line, and you get a falsely effect of incorrect placement of these calipers or demarcations. You get a smaller ICT and a wider IRVT, even though this is not really the case. If I go back to this, it's the same signal, only because it's drifted up and down the zero line, you get a wrong measurement. And we tend to overcome this problem by a new technique, because this is a clear example of fetal drifting due to fetal movements, maternal breathing, aorta pulsations of the mother. This is just a real-time image. It's not real. These complexes do look quite the same, but the zero crossings are not visible. And this is a huge problem with getting MPI using collar tissue Doppler. Another problem comes with determining where the EV valve opens. You use the start of the diastole. You want to know where the AV valve opens. It's here on the E. But why don't we use this peak instead of the estimate of what is opening of the AV valve? It's not really where the ejection phase begins, but it's the beginning of a phase of the heart where the myocardial tissue starts moving and there's not really yet a jet of blood flow. And these are more easy obtained peaks in these kind of signals. So we would like to propose a different technique in which we don't use the ejection time or isovolumetric times, but we use the wall motion as an indication of contraction and relaxation movements or times, phases, because we think it's more easy to assess the myocardial wall movements than the real ejection times or the isovolumetric times where the myocardium is still. Here you see an example of an image of where the ROI is placed over the whole myocardium, and this is where we think the other region of interest should be placed, just below the AV valves. And this is an image of the whole myocardium. So if I go over this image, we can place demarcations or calipers on the beginning and ending of the relaxation time, at the beginning and ending of the contraction time. And if we calculate it as a percentage of the whole cardiac cycle and do it in repeatedly ways, we can say that the percentage of relaxation time or the percentage of the contraction time is different between fetuses or changes over time. So this is what I want to suggest as a new technique. So again, to measure the global heart movements, we place a ROI over the whole myocardium and the left and right ventricle just below the AV valves, because we think that that's the first, the place where the heart starts to starts to move at the first time. So you can use that as a marker of myocardial wall movements. Here you see an image with several cardiac cycles. You choose one cardiac cycle, and you see the clear peaks in this curve, and you use these to then calculate the contraction time. This is this, and the relaxation time is this time. You can calculate these times. So you cannot, here it says it's calculated in MPI, but it's not really MPI because we use these times as just a phase of the heart pumping. So it's just a different way of thinking. These clear markers are not, they're just indicating the contraction and relaxation phases of the heart. And it's not the same as ejection time if we look at the contraction time. And sure, yeah.
So the x-axis is only the time that you're interested in.
Yes.
You're not interested in the area under or above the curve.
No.
Just on the x-axis.
Yes. Only the times, not the amplitude. No, we could look over that, but we didn't yet. So one of the important times in fetal cardiac function is this cardiac event, the intercontraction and relaxation time. But these are very small times. We do not use them yet because we think that it's subject to measurement error because these are very tiny intervals. So we only focus on the contraction and relaxation times at this time. And is this a reproducible technique? We assess reproducibility in our center, and we show that there's a high feasibility and reproducibility, especially in the global heart setting and in the right. And for the left, it's more difficult. But this is completely different than from the MPI, whereas the right heart is impossible to measure, or you have to have a modified MPI measurement. So I think that's one of the advantages of this technique is you can measure the right-sided heart and you can measure a global cardiac wall movement as an indication of fetal cardiac function. But is it possible to detect fetuses with reduced cardiac function? One of the main topics in our center is TTTS, and we know from previous research that up to 70% of recipient twins the cardiac function is compromised, as shown on echocardiography. But our current staging system does not yet include cardiac parameters. So our thought was maybe we could implement these easy obtainable images and cardiac time intervals into our staging system. So for an example, I want to show you some images of a recipient twin. If we look at this image, you can see 2.5 cardiac cycle. But is this discriminative? By looking at this image, you say yeah, it could be different from the other, but is it? This is a different fetus, but what I want to show you, to the left you see a control patient, and to the right you see the recipient twin. And what seems to be different is that there's a reduced relaxation time and an increased contraction time, which is already known, but we can also discriminate these fetuses with our new technique. And if we take a look at the global heart right ventricle and left ventricle, we see that in all three images, we see a prolonged contraction time and a shortened relaxation time in TTTS recipients. So possibly we can detect fetuses with an advanced disease by picking up these cardiac time intervals. We have to elaborate or investigate this finding more, but it seems promising. So to conclude, I want to say that this is a measurement of cardiac time intervals by collar tissue Doppler imaging is easy, it's highly reproducible and discriminative for now in recipient twins versus healthy singleton fetuses. And we have to further validate this technique and investigate whether we can discriminate in other pathological pregnancies, and to see if we can implement these measurements into clinical practice. Thank you for your attention.